As we go through this panel discussion, I think I'm going to look to each of you then to make the point about how some of these new agents we have improved outcomes for patients, and then the pushback has to come from clinicians to pathologists and to our universities or our local hospitals as to what we need to take the best care of patients. And so that we have to show the value of that. But Naval, can we wait? Can we wait for this information?
Yeah, I think in general, the value that is gained by getting this information and the ability to select the appropriate therapy or addition of therapy, whether it's midostaurin for FLT3, whether it's CPX351 in the secondary AML, whether it's HMA-VEN or HMA-IDH in the elderly IDH mutated, I think the general improvement in response rates as well as survival is much more important than rushing into therapy and then finding out later that, oh, we could have done something that's better. There's also data at this year's ASH. The German colleagues, Christoph Rolleg et al., presented a large analysis of German cooperative groups studies from the SAL group, and what they basically said, and I think we have to preface this with saying that these are patients who went on trials. So I don't think it's a direct extrapolation of what can happen in the community, because we know there are some patients who are sicker and do not go on trials, and I think there has to be individualized decision, can you wait? But it looked like for a large majority of patients, when they were being monitored by an academic center in Germany, being followed closely, there was no difference in the outcome waiting 5 days or more, and they basically made the point that it's more important to get the molecular, the FISH, the cytogenetic information, and waiting did not seem to impact the outcome, but getting the right decision did impact the outcome. So again, I'm not saying if you have somebody with 70,000 white count, you know, it's coming with pulmonary infiltration, you wait, but those are the outliers. But for the large majority, you could do it.
But something also, like we always talk about waiting. Waiting doesn't have to be not doing anything. Yes. Because you could be like putting those patients on Hydrea, you could use some low dose RSE, like, you know, you could start some treatment,
antibiotics,
tumor lysis, prophylaxis. Like, so waiting could be doing stuff. Like, it doesn't mean that we are not doing anything for those patients. But I think the major decision on the, you know, major treatment or the main treatment, the induction strategy, can wait. So.
Yeah, and Robbie, that point was made during the question and answer session that they did not include the use of hydroxyurea in that, you know, wait time, and many of patients may have received it. And I find it very effective at lowering the white count, and it gives you time to treat infections and get tumor lysis under control.
This is where I find getting the rapid FISH back is helpful. Sometimes if I've got a patient on the borderline, high white count, unstable, I want to start treatment, if I can at least kind of reassure myself that I'm not dealing with a P53 mutation, I'm more willing to, you know, I do wait, but you can kind of still grade it. The lower, more indolent AMLs or less aggressive ones, I almost always know we are not touching until we have, you know, a more comprehensive picture.
So before we leave this section, Mark, talk a little bit about the difference in prognostication between FLT3 ITDs and TKDs, and what about this allelic burden?
So again, it's important to understand that the next generation sequencing test is what's going to get you usually your FLT3 TKD. That is a point mutation in the tyrosine kinase domain of FLT3, maybe 7% of AML walking in the door. Not a huge prognostic impact, but a big impact in your choice of therapy. You've got to know about this. That's likely going to be reported on the next gen panel. The PCR assay, which is still what most people are doing to identify the more common FLT3 mutation, which is an ITD mutation, internal tandem duplication, is going to be available sooner if the clinician knows to ask for it. That's a much more important mutation to know about prognostically. But then there's another layer of information that goes along with it, and that's the relative amounts, the allelic burden. Now, most oncologists are used to describing things with a VAF, a variant allele frequency. And really, I have seen diagnostic companies now reporting the FLT3 ITD as a VAF. We had this old-fashioned thing where we divided the amount of mutant by the amount of wild type, and that was called an allelic ratio, which no one else uses for anything else in oncology. And regardless, it's the amount of ITD mutant that you've got. The more you have, under any circumstances, whatever you're doing, the worse off you are. These are not standardized assays. So in ELN guidelines, where they clearly state something called 0.5 allelic ratio. Above is bad and below is not so bad. Okay, so if you repeat that same assay 3 times, you get 3 different results. So I don't recommend using the allelic ratio to make big treatment decisions. I totally concede that assays that show there's more ITD present is bad, but I don't generally advise using it for clinical decision making.